Well, in short, what this all meant or this slide means is basically it says or suggests that if a poor metabolizer is taking a racemate metoprolol, then there will be an accumulation of R isomer, whereas if he is taking S-metoprolol, that is chirally pure, then he won't have the problem of side effects due to beta 2 blockade. So this is basically what this slides wants to convey. So now moving on to the next, well, we are going to discuss about, who are these? Well, these are, as many as you can see, are the poor metabolizers. So general population, it is approximately 30%. Well, some studies say that in India there are 2 to 5% patients who are poor metabolizers. Then uh, what are these now? Why do we need to talk about these CYP2D6 inhibitors? Well, as you are aware of that CYP2D6 is an enzyme which is found in the liver cells or produced by the liver cells, belongs to cytochrome P450 group, and it is responsible for the metabolism of metoprolol. Well, as we have studied that there are two groups, there are extensive metabolizers and there are poor metabolizers of metoprolol. Well, if the patient is concurrently at the same time taking CYP2D6 inhibitors like cimetidine, ranitidine, chloroquine, diphenhydramine, or even ciprofloxacin, then the chances is that if at all, if he is an extensive metabolizer, then he will soon get converted to a poor metabolizer, and he will have accumulation of the beta to of the R isomer, that is which is responsible for the beta 2 blockade activity. So if patients, now let's talk about the safety, whether this drug is safe in hepatic insufficiency patients. Well, patients with hepatic insufficiency have impaired function of CYP2D6, and impaired metabolism of the racemic metoprolol leads to conversion of extensive metabolizers to poor metabolizers. Consequences are similar to those seen in poor metabolizers after administration of racemic metoprolol. So if a patient has first deficiency or insufficiency of liver functions, or he has impaired liver functions, then his CYP2D6 levels will be low. So simultaneously there will be an impaired metabolism of racemic metoprolol. All extensive metabolizers will get converted to poor metabolizers, and these poor metabolizers will have accumulation of R isomer, which is responsible for its beta 2 activity or beta 2 blockade activity. There will be loss of cardioselectivity, and there will be adverse effects of R isomer seen in these patients. So it is unsafe to prescribe racemic metoprolol to these patients with hepatic insufficiency. Similar is the case when you are taking CYP2D6 inhibitors, then you get converted to poor metabolizers. So because they are the enzymes which are responsible for conversion of metoprolol. So once you are taking an inhibitor, that enzyme gets blocked, the metabolism does not occur, so the patient becomes a poor metabolizers, and following are the complications what I have listed, like the adverse effects related to cardioselectivity, loss of cardioselectivity, and other beta 2 blockade activities. So patients should simultaneously not take CYP2D6 inhibitors when they are on metoprolol, that is racemic metoprolol. That is a message what I wanted to convey. And simultaneously those who have got hepatic insufficiency should ideally switch to S-metoprolol because it is safe. Now, S-metoprolol is the preferred choice in congestive heart failure and post-MI patients. Well, what are the effects of beta 1 blockade on heart? Well, bradycardia allows longer time for diastolic filling, reduced cardiac oxygen consumption, antiarrhythmic activities, inhibition of catecholamine myocardial toxicity. So these are the effects of beta 1 blockade on heart of the metoprolol. So are all the beta blockers, or to be precise, beta blockers, well, all the beta blockers the same? Well, beta blockers have been studied. They can be beta 1 selective, they can be non-selective. Well, of the beta 1 selective, we have the atenolol, we have the metoprolol, and bisoprolol. Well, the non-selective ones are timolol, then you have propranolol and carvedilol. So these are the three non-selective beta blockers. Well, the choice lies the agents which has proved effective in long-term clinical trials, and these are the metoprolol, timolol, propranolol, and carvedilol. More lipophilic agents, it is metoprolol and carvedilol. So you have a choice now, and you have segregated into two now, metoprolol or carvedilol. So choices, again, you agents with intrinsic sympathotome and mimetic activity like pinodolos and acetoprolol should be avoided. So your final choice lies between metoprolol and carvedilol. Metoprolol has the advantage of being beta 1 selective. So and plus you have the results of clinical trials in favor of metoprolol. So we'll talk about this. This is an overview of all the trials. You can see the mortality percent reduction in the mortality in the different trials. We can see with ethanol -15, propanol ranging near 25%, timolol less than 40, whereas with metoprolol it is 40%. So again, the proven benefits of beta blockers in trials after acute myocardial infarction. You can see the reduction in mortality. It favors metoprolol, favors reduction in mortality in the early days, plus late mortality reduction is there. There are chances of less sudden cardiac deaths, ventricular fibrillations, and ventricular arrhythmias when the patient is on metoprolol. Then going on to the next, this is the MERIT-HF trial. Well, the full form of MERIT-HF is, it is mentioned here, that is, well, it is metoprolol CR/XL reduce. Well, this is a trial which we spoke about, CR/XL randomized intervention trial in heart failure. So patients with CHF in New York Heart Association class 2 and 4 with an ejection fraction of 40 or less and a history of being hospitalized for acute myocardial infarction were randomized to metoprolol succinate, controlled release and extended release tablets versus placebo. Well, metoprolol CR/XL reduced the mortality by 40%, that is the total mortality reduction. Sudden cardiac deaths reduced to 50%. Then mortality or hospitalization for worsening of the congestive heart failure was reduced to approximately 30%, and cardiac deaths due to non-fatal MI reduced to approximately 45%. So there was a post hoc analysis showed that the outcome in patients with earlier revascularization and outcome in those with more severe CHF was similar to the entire post-MI population. Well, this trial was, there were two trials which were done. One was the MERIT-HF, then was the Capricorn trial, which spoke about post-MI patients or with left ventricular dysfunction. Well, both trials revealed the beneficial effects of respective beta blockers in post-MI patients in presence of risk factors that in earlier days precluded beta blocker use in post-MI scenarios. So the doctors got confident after we had these two landmark trials related to beta blockers. So we go on to the next slide now. Well, this is again the main findings in the placebo-controlled trials on patients with mild to moderate heart failure. You can see that metoprolol is scoring over carvedilol. Well, reduction in progressive heart failure was appreciable with metoprolol, whereas with carvedilol it had mixed results. Then improvement in quality of life was definite with metoprolol, whereas with carvedilol it was again not significant. Then we have the next slide which highlight the comparison of outcomes of mortality reducing beta blockers in patients following myocardial infarction. You can see that metoprolol tartrate was effective in all these three groups, where first is the mortality reduction in general population of post-MI patients. This was effective, whereas carvedilol was efficacy was not established. Then secondly, it was effective in sudden death reduction, whereas it was uncertain for carvedilol. It was again the reinfarction reduction, it was effective metoprolol, whereas again there was a trend towards uncertainty in carvedilol. So it was again scoring over the carvedilol groups of patients, and it was effective in these smaller parameters. So again the mortality reduction in the MERIT-HF trial was 34%, which was the maximum achieved. So these were the trials which were favoring beta blockers. Now we talk about the comparison of metoprolol with carvedilol. Well, there was a mortality reduction of 36 to 40%, whereas with carvedilol it was 23%. Well, there was a significant reduction in the reinfarction rates when metoprolol was administered to the patient, whereas with carvedilol it was non-significant. Sudden cardiac death, again a significant reduction with metoprolol, whereas non-significant with carvedilol. Then combined endpoints of all-cause mortality, hospitalization for cardiovascular causes, there was a significant reduction in patients receiving metoprolol. On the contrary, carvedilol, it was non-significant. Well, patient population, normal LV function, that is the Göteborg trial, the CHF, MERIT-HF trial. Only left ventricular dysfunction patients were studied with carvedilol. So these are the points which score metoprolol over and above carvedilol, and it proves its efficacy in multiple parameters. So again I am highlighting that metoprolol is a drug which is of choice when you are thinking of post-MI patients prophylaxis. So what are the indications of MetPure XL? Well, it is hypertension, angina pectoris, stable symptomatic NYHA class 1 to 3 heart failure with impaired systolic left ventricular function as an adjunct to existing heart failure therapy, prevention of cardiac death and reinfarction after acute phase of myocardial infarction. Well, the dosage and administration, well, metoprolol 50 milligrams is intended for once daily administration and is preferably taken in the morning. A mild to moderate hypertension 25 milligrams OD, and it can be increased to 50 to 100 milligrams. And angina pectoris 50 to 100 milligrams OD and can be combined with other anti-anginal agents. For prophylactic treatment after myocardial infarction, 100 milligrams OD is prescribed. Well, in stable heart failures class 2, well, you can initial dose for 2 weeks is 12.5 milligrams, which can be increased to 25, and thereafter it can be doubled every second week. The target dose for long-term treatment is 100 milligram OD. While in class 3 and 4, you can start with 6.25, after first and the second 12.5, for further 2 weeks 25 milligrams. In those patients who tolerate a higher dose, the dosage can be doubled every second week up to a maximum dose of 100 milligram daily. Well, this is very complicated. The dosing schedule, where the doctor will be the best person or the best judge when he has a patient with MI and CHF simultaneously when these diagnoses are made. So you should be aware of the dosing schedule, and you should be aware of the indications where your medicine can be prescribed. So moving further ahead, we will be talking about the clinical reprints and the mind maps. Until now, I wish you all the best. Hope you have understood metoprolol, you have understood the details related to the metoprolol, the benefits, the advantages of beta-1 blockade, and of course we don't talk about the beta-2 blockade. We actually talk about only beta-1 blocking activity and the cardioselectivity for metoprolol. So with this, I wish you all the best. Thank you.